Okay, everyone.
Okay.
So we are live and recording this. I'm
Yeah.
Bill Aufferman. I'm going to be talking today about an introduction to chest radiography, kind of picking it up from where Dr. Mann left off a little bit earlier. And like I said, we will be having quizzes at the very end of the 2 hours. And please feel free to ask questions as we go along. Um, okay. All right. Let me just make this smaller over here. All right. Okay. And like I said, if there are any questions, please feel free to call in. Okay. All right, so we're going to be talking about chest radiography today. So first, I just want to talk about, and you'll notice my little disclaimer down here. These are things I think every non-radiologist should know about radiology. And this kind of goes over everything, not just chest, okay? So I think these are three high points for those of you who aren't going to radiologists. Number one is radiologists need history. This is like a big peeve that we all have. So here's a great example. So let's say this is a chest radiograph that you're interpreting. You'll see there's this big, opacity right here. Okay, so now imagine you had the following two histories for this patient. A 28-year-old male with fever and cough, otherwise healthy, versus an 82-year-old male with chronic cough, weight loss, and a history of heavy tobacco use. I think most of you would agree that your differential diagnosis for the same radiograph would probably be rather different if you got those two disparate histories. And so this is just an example of why radiologists need history. And there are a few reasons for this. The first is that there are many imaging techniques and ways of imaging various parts of the body, and that will also change the way you acquire images for a given modality depending on what you're worried about. For example, one would acquire a CT differently if you were worried about an aortic dissection versus a pulmonary embolism. Okay, so it will basically, the correct history will allow us to pick the correct imaging modality to do the correct protocol, and also it will allow us to narrow the differential diagnosis. Like I said, more specific histories can help narrow the differential diagnosis better than non-specific histories. Okay, and just like it doesn't need to be exhaustive, okay, but an example of a helpful and non-helpful histories are shown here. And this is a very common one. Everyone see this eval chest? Everyone see that there? Yeah, we get those kind of histories quite frequently. So imagine getting a CT requesting eval chest. You have no idea what someone's looking for versus here, a 33-year-old female with leg swelling, tachycardia, and dyspnea. There, I think it's pretty clear they're probably worried about a pulmonary embolism. We could protocol the study accordingly and pay a special interest to the pulmonary arteries. And so that's number one. Number two is that if you don't know what study to order, please ask. There are a lot of online resources to guide one towards the best imaging workup for a problem. And it's wonderful if you know what to find and how to use it. But and here are some resources shown here, such as the American College of Radiology has very helpful appropriate use criteria for various imaging techniques for various indications. But there's a lot of information out there. It can be confusing. And if you're having a hard time, just call the reading room and talk to a radiologist. We're always happy to help you guys. And last but not least, read the report, please. You'd be actually surprised at the number of times that a radiologist, that I'm sorry, that clinicians who order studies do not read the report. And this is actually significant failure to follow up appropriately on imaging findings or significant source of medical malpractice litigation. So please be sure to read the report. I think that newer EMR systems will actually let you know when you have a new study report in your inbox and will prompt you. So I think this actually makes it easier than in the days of old before that was the case. But please do be sure to look at the reports for the studies you order. Okay, so that was just a brief overview of got to get up my soapbox here and tell everyone what I think non-radiologists especially need to know about radiology in general. Any questions about that before I move on to the remainder of my talk? Open for questions? Going once? Going twice? Okay, moving on. So now I'm going to talk more about chest radiographic anatomy. So Dr. Mann gave a talk earlier this morning. I'm going to be focusing on some different aspects than what he focused on. There'll be a little bit of overlap, but I think that the overlap we'll have will be healthy and as a nice preparatory step forward into the remainder of this talk. And so, yeah, so basically chest radiographs are acquired using X-rays, okay? X-rays are a form of ionizing electromagnetic radiation with energy higher than visible light or ultraviolet light. So that's when people are worried about radiation in an imaging study. It's not really just radiation, it's ionizing radiation, okay? And that's actually fairly specific. Because like MRI, for example, does use radio wave radiation, which is non-ionizing and is not known to cause cancer. So X-rays are required using, radiographs are required using X-rays. And so the reason that they're helpful is that when a material is exposed to X-rays, three things can happen. Some radiation is absorbed. I don't have this here, but some is scattered. That really doesn't, that they're scattered, and also some radiation is transmitted that goes through. And X-rays are projected through a patient. The transmitted X-rays are recorded on a device to create the image of the chest. So shown here is my high resolution image of a human being imaged using an X-ray. And you'll notice you've got your X-ray source. The X-rays are transmitted through the person's body onto a detector. And what we see here, I don't know if any of you guys remember film cameras, probably before a lot of your times, but what you basically have here is the photographic negative of the image, where the dark areas are exposed to a lot of X-rays and the lighter areas are not exposed to any X-rays. So that's kind of why we have the color coding scheme we do. It's from this is basically the negative of an image, similar to the images required using film on a camera. And you'll notice once again that what we're looking at is X-rays that are transmitted versus those that are absorbed. Okay, and that's how we generate our images of any part of the body. In this case, we'll be focusing on the chest. Now, the radiographic densities, generally speaking, the absorption of X-rays occurs on a continuous spectrum, but for the purposes of imaging most parts of the body, including the chest, you can kind of break it down into basically 5 categories. So air is very similar to vacuum in that it absorbs virtually no X-rays, and so you'd have the most X-rays passing through, and that would correspond to that area being dark. Fat absorbs X-rays, but not very strongly, and so that would be, kind of the first shade of gray you would have going from black to white. Water and soft tissues is a bit more intermediate, higher than fat, and then you have bone, which strongly absorbs, followed by metals. Steel, lead, what have you, very strongly absorbing and will be the brightest on an X-ray image. And so you'll see here, we don't have metal on this image, but you'll have your air, your fat, your soft tissues, and your bones. And if there were metal, it would be even brighter. Okay, so basically this is how you form your radiographic image and how you can use the, roughly speaking, the radiographic density to tell what's happening in a given location. Okay, and like I said, if anybody has questions, please feel free to chime in. I'd like to answer them as best I can as we go along, assuming there are not too many. Okay, now we're going to talk about the silhouette sign. Okay, so once again, briefly remember that there are 5 different radiographic densities from order of least attenuating to most attenuating, with air, fat, water, soft tissue, bone, and metal. And now we have the silhouette sign. This is a very important sign. This lets you tell when there's something abnormal. Primarily in the lungs is where we use it the most. And this occurs when you have 2 objects of similar radiographic density adjacent to each other and in contact with one another. And when these 2 surfaces are in contact, the border between them is lost. So here's an example. Oh, that image didn't come out very well. I don't know what happened. But anyway, so 2 X-rays of the chest. You'll notice in one case, you've got a clearly demarcated left heart border and left diaphragm. And you'll notice here, I don't know what happened to this image, but you'll notice here, like the diaphragm, it's confluent, it seems, with this opacity over here. This is an example of the silhouette sign because you have 2 objects of similar radiographic density, which are in contact, and the border between them is lost. Okay, so that tells you where this occurs, all right? So if you have 2 objects, an object being silhouetted, you know that it's in contact with the object adjacent to it, if that makes any sense, okay? Like I say, please chime in with questions if there are any. So this is very important. So if you have something silhouetting the diaphragm there, you lose that border, you know it's touching the diaphragm. if you lose your aortic border and there's opacity over here, you know that whatever that opacity is, you don't know what it is, but you know that it's touching and in contact with the aortic knob. Same thing for the chest wall, and like the vessels up here in the upper thorax. So that's very helpful for localizing the position of an abnormality. And there's a zoomed in example of where better here, we didn't get as pixelated, showing where the diaphragmatic contour is lost. Okay, so now we're going to talk briefly overview some anatomy for chest radiology. And like I said, Dr. Mann went over this in greater detail before, but I'll review the pertinent highlights because it'll be germane to our discussion about abnormalities in the chest a little bit later. So for frontal radiographs, the basic structures you'll have to think working from kind of the center of your image towards the periphery would be your airways, your trachea, right and left mainstem bronchi. Your mediastinal structures, your heart, your left and right hyla, the aortic knob. And as you can see, this is your pulmonary vasculature kind of arborizing or branching as it moves central to peripheral. The structures of your chest wall, these are the scapula, clavicles. Here you can see a little bit of the manubrium of the sternum. Really don't see the rest of the sternum too well, typically on a frontal chest radiograph. And your ribs. So these are the posterior aspects of the ribs. And as they curve around, right, they transition to the anterior aspects of the ribs, which are typically less well seen. And then, of course, you have your upper abdomen with your little air bubble there in the stomach. And that's a whirlwind tour of the chest radiograph. Frontal view, now in the lateral view, yeah, something happened when I converted these images. They're not projecting well. But over here is your, wow. Yeah, this isn't projecting very well, I'm sorry, but your scapula, you can see a little bit of them here. That's your sternum anteriorly. The spine, normally the spine from this point in going superior to inferior should become more lucent, and this is due to decreasing overlying soft tissues. This is the heart here. This linear boundary over here at the back of the heart is your inferior vena cava, the IVC. Yeah, you don't see it well here at all with this. I had to convert to PDF. I was having trouble with PowerPoints on this computer. And you don't see the aorta, main pulmonary artery very well. There's your trachea. You can get a little bit of sense of your right upper lobe and left mainstem bronchi. And these are what they typically call the clear spaces of the chest. Your retrosternal clear space, the retrotracheal clear space, and the retrocardiac clear space. So if you see opacities in these areas, you want to start thinking about the possibility of an abnormality such as a pneumonia, recognizing that the clarity of these areas is a function of body habitus, technique, lung volumes, overlying soft tissues, what have you. Okay, so now I think this is extremely important, okay? Now, the lateral radiograph, people say, well, I mean, I don't use it for a lot. Why do we need it? So two views of a radiograph are actually very important, okay? And I'll show why. And that they help with overlap when structures are superimposed. They help deconvolve overlapping structures, okay? Again, because overlapping structures can sometimes lead to erroneous conclusions. So here's a picture of Prince William, if you recognize him, after the birth of his children. Does anyone have a guess of what he's doing in this picture? Okay, well, this is where two views come in helpful. So I switched to the second view there. It's his third child. I dare say many people might come to an erroneous conclusion based off of the single lateral projection. So this is a great example of how two views are helpful. A more radiographic, something more radiology oriented would be shown here. Little child fell and has some leg pain. This looks pretty normal. I would have called this normal. I don't know about the rest of you, but we get the lateral radiograph and oh my goodness, this is the same patient. Just so you all know, this actually is the same patient, AP and lateral radiographs of the tibia. And here you see a fracture that was completely missed. I would never have called this. I don't know anyone who would have called this abnormal on the AP radiograph. And so an example from chest, which is helpful. Look at this little thing right there. Now, what is that? Huh? So it's kind of in the location where you'd expect to see the azygos arch or the azygos vein. Um, but it's too radiodense. The shape isn't quite right. I mean, what did they swallow something? I mean, is that a retained foreign body? Well, this is where the lateral radiograph can come in helpful. A little harder to see here, but if we zoom in a little bit, see that over there? Can you kind of see those holes right there? Anyone have a guess what that is? Let me see if we can look at some.
A swallowed button?
A button. Yes, it is a button. Okay. Um, Oh, you guys didn't hear Dr. Mann's lecture. Oh, sorry, I just see that on my notes over here. Yeah, and people a lot of this stuff is actually be interactive, so I love it when people do chime in. That's encouraged, okay? So yeah, that's a button. So this is an example of where a lateral radiograph can be very helpful, okay? And so that's your whirlwind tour of radiographic anatomy and whatnot. Do we have any questions? Like people, please chime in. I want to answer questions as we go along. I want people to get something from this.
I have a question
Go for it.
about the silhouette sign,
Mhm.
and then also with the subsequent discussion on superimposed images.
Yep.
You seem to emphasize that for the silhouette sign to be present, they had to be in contact with each other.
Yes.
Is it possible to have a silhouette sign with two objects of similar density simply being superimposed but not necessarily in contact?
I love the question. Okay, that bothered me when I was like a med student too. Now the answer is theoretically yes, but the probability of two things not being in contact, but having that exact, it would have to have the same shape though, right? To have the same radiographic density. Do you know what I'm talking about? And be in the exact right location. So the probability of an object, having a concave border, the same thickness, the same density, and not being in contact is pretty close to zero. Does that make sense?
Yes, it does.
Yeah. So theoretically, it's a possibility, but practically, I mean, if the probability of that happening is so close to zero, it's not even worth entertaining. So yes, it is possible, but pragmatically speaking, that won't happen. And you had another
Thank you.
question, I believe, or was that?
That was my only question.
Okay,
Thank
good,
you.
good. No, great question. That used to bother me too, but you are right. So technically it could happen, but and basically, essentially, probabilistically not. Any other questions? Okay, moving right along then. Now we're going to talk about some common abnormalities. So for central venous catheters, now I'm just kind of curious. Is there a way we can do a straw poll here? Are most folks here, how many people are on? Ooh, a lot of people are on. So these are I think what I'm gonna go over now is very important for both radiologists and non-radiologists. So a lot of this talk is focused on things everyone needs to know, radiologists and non-radiologists alike, because, so just so you're aware, even if you're not going to radiology, this is something you need to know about, okay? Central venous catheters, these are a very important cause of morbidity and mortality in patients, especially hospitalized patients in the ICU. And it's also a big source of litigation because remember, first do no harm. If you inserted a central catheter and you injured a patient, you have caused harm. Okay, so it's a very significant source of medical malpractice, and recognizing malpositioned catheters is very important. So a central catheter is by definition an intravenous line that's inserted into a large vein, such as the superior vena cava, typically with its tip near the heart, right, for therapeutic and diagnostic purposes. Okay, and this is an example of a central. Wow, those arrows completely moved. I don't know what happened. Yeah, I was having some problems with PowerPoint wasn't working on this computer very well, so I transitioned this to a PDF. Things got a little bit garbled when I did the transition to PDF, a few minutes before this talk, so I apologize. This is the catheter here. This is what it's supposed to be pointing at. And so basically the peripheral comes into a central vein and then extends centrally. And when placing these, radiography of the chest is often used to confirm correct positioning. Okay, we're going to go over that now. And so that's important because once, as I said, malpositioned catheters can cause iatrogenic injury. And it's also important to distinguish central venous catheters from overlapping external structures. Lines in EG and G tubes, especially the peripheral portion, which can either internal, which can overlap the esophagus, or external, which can overlie other parts of the chest. You're going to have overlying catheters and monitor leads that can be confusing. Generally, they'll have non-anatomic courses and can be readily distinguished from abnormal central catheters, but not always. And occasionally, you will get malpositioned catheters that are outside the veins, either in an artery or extravascular, okay? So once again, we talked about the vasculature here, and these are basically where you will have the larger vessels of the chest living, okay? So your right atrium is going to be right here, okay? And below that, your inferior vena cava. Generally speaking, insertion of central catheters through the lower extremities can happen, less commonly so. So we're going to focus on upper torso insertion of central venous catheters. They'll come in typically via the subclavian veins, okay, or your jugular veins. Now, of note, and this is like your superior vena cava here, which extends roughly from the superior module of the aortic knob to the level of the right atrium, where you just start seeing the right atrium pooch out over here. Okay, so basically this is where your SVC is going to live, and this is where you're going to want your catheter to be in the mid to low SVC typically. Dialysis catheters, you'll want them a little bit lower, but generally you're going to want your catheter living somewhere in this region right over here. Generally right at the atriocaval junction is ideal, but you know, as long as there's somewhere in here, usually that's okay. All right. Now, a few important things to note. Remember, an important thing about your subclavian veins is they are below the clavicles, okay? If a catheter goes above the clavicles, you start needing to worry about an arterial catheter or an extravascular catheter, okay? And then your jugular veins, once again, live right over here. And let me see, your central venous catheter should have its tip somewhere in here, preferably in the lower half. Okay, so normal positioning. Here's a good example of normal positioning of a subclavian catheter. See here, you've got your catheter going with its margin inferior to the superior margin of the clavicle. And once again, so this is what I was talking about. You've got all these external catheters over here. I know when you look at some ICU films, you know, they have so many overlying monitor leads. You almost wonder if somebody told the technologist, put all the monitor leads you can find on the middle of the patient's chest and get the image. Makes things very hard. And so here's an example of normal positioning. There's your tip. Another example, a left subclavian catheter, you know, of course, is just below the superior margin of the left clavicle. And here is a NG tube and ET tube overlapping a little bit. There's your tip. So now we're going to talk about abnormally positioned catheters, okay? Hey, now this is an interactive portion here. You guys can tell me where these things are going. Feel free to chime in. Where's this catheter going? Where's its tip? Come on. Somebody sees this. Guys. Really? Nobody?
It seems like it's over line. Oh, sorry, yeah.
Yeah, so basically this one crosses midline, probably curled in the left innominate vein, okay? How about this one? Any thoughts on this one? Okay, I'm pointing to it now. Any thoughts on where it's located? Okay, this one, I'm sorry, is probably coiled in the azygos vein. So the azygos vein lives just above the right mainstem bronchus. Okay, it usually tends to be lenticular shaped right above the right mainstem bronchus. And when it forms a loop-de-loop in this location, typically it's going to the azygos vein. And here, let's see, what am I trying to show you guys here? Oh, this one's kind of neat. Anyone know what's abnormal with this catheter here? Any thoughts? Any thoughts? Right there. Anyone know where that is? What are the options? Okay, how about do people just want to like even just try to what's the word I'm looking for? Text in or okay, I'm trying to get some. It's not working there. Okay, so that's either sorry, I'm going to go back to full screen here again. Oh, better, yeah. So this is probably going into a left-sided SVC, although we can't fully exclude arterial positioning here in the aorta. So for something like this, I would say don't use it, call radiology, and just make sure that it's actually a left-sided SVC. Very often these patients will have prior CT imaging showing that there's a left-sided SVC, or you could also do blood gases or something like that, interrogation with waveforms. Realize that there is a possibility of error in those cases. If someone's very hypoxic, blood gases won't necessarily always give you the right answer. But for something like this, this is an abnormal course. I would not use the catheter unless you're completely positive there's a left SVC, and that's where this is. Yeah, I just chat with the radiologist and just confirm that this is a left SVC before using it, because once again, an arterial catheter could have a similar position potentially. Okay, how about this one? It's doing a loop-de-loop, hanging a U-turn in the superior vena cava, and its tip's probably poking back up into the right innominate vein. How about this one here? Central catheter coming down, crossing midline, tip crossing over into the contralateral right innominate vein. And so, yeah, so basically this one's making a U-turn going up on the opposite side.
Quick question, Dr. Auffermann.
Sure.
These ones that are making the U-turns and kind of looping around, those are placed correctly, right? So this is just the most preferred route for placement?
No, these are all incorrect.
Oh,
every case
great.
I've been going over has been incorrect.
Okay.
They're all abnormal positionings. Yeah, so you definitely, you want the catheter tip to be over here in the superior vena cava. That's the only place you want it to be present. If catheters in other locations, they should be repositioned. Okay.
Can I ask a question as well?
Sure.
Doesn't it make more sense to just always go from the right side of the patient, because it seems like the travel distance to the SVC is shorter than going in from the left side?
Yeah, and there might be reasons why you don't want to, like especially like I'm thinking of a few common cases, like in I know not as much here, but in other places, like in some of your sickle cell patients, they get a lot of central venous access and they tend to burn out their veins, so they might have no veins left on their right side. If they have cancer, they might have a stenosis if they've got thrombus. So generally speaking, what you're saying is accurate. And then again, if somebody has a lot of catheters present, like some of these ICU patients have numerous central catheters, they've got an internal jugular catheter, they've got a swan catheter, pulmonary arterial catheter. So sometimes you might have so many catheters on one side you want to move to the other. Or if you've got an infection at a catheter insertion site, you might need to switch to the other side. So you're correct. Very often, it might be easier on the right side, but sometimes you have to move to the other side. But that's a great question. Yeah, okay, keep the questions going, guys. These are great. These are great. I'm going to make sure people understand this stuff. Okay, so this one here. Now this is another example of where you've got a lot of overlapping stuff, right? So these are all external to the patient over here. Okay. This is a normally positioned right subclavian, but look at here's ET tube and G tube coming down. I windowed it so you can see the central catheters. You don't see that well, but look at this one, right? Crossing midline over there and going into the wrong side. Now this one, because it's so low and is projecting over the aortic knob, is worrisome for anyone? An arterial line, right? So it crosses midline, projects over the aorta. Every once in a while, you can have patients with a bit of a lower innominate vein, but I would basically, as far as I'm concerned, I would say don't use this one. This could be an arterial line, unless you've got like a CT showing that actually they've just got like a low left innominate vein, and this is actually still not well positioned, but yeah. So this is actually concerning for an arterial line. And there's one important thing to note about an arterial line. What would you guys do if you found an arterial line other than not use it? Any thoughts? Okay, so okay, so basically you don't want to just pull these out. So venous lines, the veins tend to be a bit more superficial and lower pressure. So when you pull them out, you apply pressure, they stop bleeding. An arterial line, if you just pull the catheter out, it might be it's deeper, and you might not be able to put down enough pressure to be able to get the bleeding to stop, so someone could exsanguinate into their neck. So typically for these, you'd call vascular surgery and tell them there's an arterial line, and they need to basically, close the arteriotomy site when they remove it. So you don't just want to pull an arterial line. That's actually really important, okay? Right. Right here, oh, I gave you guys the arrow here. Here the catheter is doing a loop-de-loop in the jugular vein, and the tip looks like it's probably in the high SVC. And so that's it for catheters here. So now I will just add one other thing that's helpful. All the catheters I've shown starting from abnormal position here going forward are abnormally positioned. Some of them are worse abnormally positioned than others. You definitely don't want to use catheters that are potentially in the arterial or mediastinum, like an extravascular catheter. But something like this, though, I have seen some people say, you know, the patient's coding. This is the only vascular access we have. All we're doing is giving saline. And so I have seen people just at times saying, you know what, we can't give up this access right now. And if they're just giving saline, that's probably okay for the short term, recognizing once the patient's like stabilized and they're not coding anymore, they're going to reposition the catheter. Okay, so not all abnormally positioned catheters are equally abnormally positioned. But they should all be repositioned at some point, and you definitely should not use arterial or extravascular catheters. Okay, is that good for everyone, or are there more questions? Going once, going twice. Okay, now ET tubes. The carina is right about there, okay, and the thoracic inlet's right here. So most ET tubes should be about 3 centimeters above the carina, right there. So kind of like, generally speaking, right, about halfway between the carina and the clavicles. Like depending on patient positioning and lung volumes, that might change a little bit, but roughly speaking, if it's halfway between the carina and the inferior margin of the clavicles and the carina, you're in the right ballpark, okay? And there's the outline of your trachea right there. Okay, so this basically shows you know, the range where you'd want it and kind of the optimum place right about here, like I said, about halfway ballpark. And shown here is an example. I'll remember our friend with the malpositioned PICC line over here. Well, there's his endotracheal tube. That's positioned fine though. Possibly yeah, that's good. See right there, the carina is probably about there. Inferior margin of the clavicles, roughly halfway ballpark. Anyone know what's happening here? Good or bad? There's the carina, there's the tip of the ET tube. You've got a right main stem intubation. May or may not be why they've got an opacity at the base. This might be some collapse from atelectasis due to the right main stem intubation. Okay.
Sorry, can you point out the carina again?
Yeah, and this is why radiography is hard. Sometimes these things are hard to see. Much easier on a PACS system with a good monitor. So the carina is right there, and this is going beyond it. So poking into the right main stem. Okay. Hey, and by the way, guys, thank you for asking questions. Please, please, please ask questions. I want to make sure you guys understand this. And if I'm an inpatient in the hospital, I want you guys to do a good job looking at my radiograph. Okay. How about here? Any thoughts? Look at that. There's the ET tube. What's wrong with it? Any ideas?
Way too high.
Way too high, above the thoracic inlet, right? You could be like ventilating this person's stomach with how high this is. And that's the balloon up there. So it's actually inflated in the larynx. This is really bad, okay? So you definitely want to reposition this one. Okay. Oh, this is a good one. Almost not fair. I almost feel a little guilty about showing this to you guys, but anyway, life's not always fair. What was the scoop on this one? Any ideas?
Left main stem.
Yeah, but isn't this interesting though? Look at that. Look. Doesn't that look a little different than the other ET tubes you've seen?
Mm-hmm.
Yeah. So like I said, this isn't entirely fair. You are correct, right? But this is actually okay though. So see this other little border over here? This is actually a dual lumen ET tube so that you can ventilate the lungs separately. Now this is a hard one. So when you see main stem intubations, it's usually on the right because the left main stem comes out more horizontal. I have never seen an accidental left main stem intubation. I guess technically it could happen, but like I've never seen it. I don't even know if I've read about it. So like this is a little unfair, but just do be aware that sometimes for thoracic surgery, they'll do a intubation with a dual lumen ET tube so they can ventilate the lungs separately. Why might someone want to do that?
You want to deflate one of the lungs so you can operate on it?
Exactly. Very good. So if you've got like taking out a nodule on, let's say, the right side, and you want to still ventilate the left so you don't have to put them on ECMO, you can do that, or vice versa. And the left mainstem bronchus, the right mainstem is very short. The right upper lobe bronchus comes off right about here. And so you really can't get good purchase in here to like isolate the lungs. The left main stem is a lot longer, so that's why they stick one of the lumens into the left main stem, inflate a little balloon, isolate it, and then ventilate the left lung through this and the right lung through this one. Okay, so that's why they have this configuration for dual lumen ET tubes. Is that you generally don't see patients on the floor with this, but just be aware that this way you can look like a star when you're on boards and someone says, "Oh my God, they've got a left main stem intubation," and you can say, "Whoa, wait a minute, now let's think about this." It's theoretically still possible, but just think about a dual lumen ET tube. Okay? Any questions on ET tubes before I move on? Going once, twice, okay. NG tubes and feeding tubes. So here's the diaphragm, okay? And NG tubes and ET tubes should definitely have their tips below the diaphragm, the gastroesophageal junction, right, which is basically occurs right kind of near the top of the diaphragm. It's a little below actually, but for purposes, just let's say right here. And NG tubes often have a side hole for additional suction. The side hole should also be below the level of the gastroesophageal junction, okay? So important, not only should the tip be below, but if it's got a side hole, that should be below too, okay? Now shown here, this is pretty normal. You've got your NG tube coming down, it's coiled, tip over lies the stomach. That's where it should be. Few interesting things going on here for extra credit for you guys. He probably has some right lower and middle lobe collapse or elevation of the diaphragm, because you see how this looks kind of low relative to the right diaphragm. The heart's down here, so yeah, they probably got collapse of both on this side here. Okay. Another example, ET tube tip there. You've got your NG tube coming down, circling, and you see this over here, guys? Okay, the tip is there. That's the side hole. The side hole occurs, I think like 8 centimeters proximal to the tip of the tube. So that's actually, by the way, kind of a way you can figure out where the tip is. Like let's say you've got your NG tube coming down here, you see the side hole, but you can't quite see the tip. If you've got something overlying, you can say, okay, well, if the side hole is here, the tip's like 8 centimeters farther and it's in the stomach. They still need to advance it, right? Or if you see the tip here, you know that the side hole is above the level of the gastroesophageal junction. It should be advanced and vice versa. Got it? Okay. Oh, this one's kind of neat. Anyone know what's happening here? Any ideas? Is there an NG tube? Is there a feeding tube? Okay, so there is. Here's the external part of the feeding tube here coming up. It goes up over and then it starts curling in the guy's larynx right here. See that? Now this is the zipper from his sweater. They should have taken that off before imaging him, but anyway. So yeah, this is actually a feeding tube coiled in the larynx. Okay? Just be aware, that's why it's kind of scary when people like give us erroneous histories and they say feeding tube placed. If they only acquired this on the chest radiograph, we look at it, we don't see anything where they're like, I don't know if they gave us a bogus history or they actually put a tube and it's coiled in the neck. So this is one of the other reasons why it's important to have a good history. And two, just because you don't see it in your image doesn't mean they placed it, because you can have malpositioned like NG tubes and feeding tubes that coil up here in the neck. Here's another good one. Ooh, this is a bad one here. Anyone know what happened on this one? You've got the arrow sign to help you. Some brave soul.
I think it went into the left mainstem bronchus into the lung. Did it go down the larynx?
Did it rupture the esophagus?
No, that went into so it's.
Oh, it went down.
Yeah, it went into the trachea. The esophagus is pretty robust. You know what I mean? I mean, it handles food. I mean, I'm sure like we've all like swallowed like fish bones or something like that and it hasn't perforated. So it's actually not that I'm encouraging that, right? But so the esophagus is pretty robust. It takes a lot to go through. So when you see something like this, it will be through the airway. Okay, I've never seen it with the esophagus. The only exceptions to that might be in someone who's had esophageal surgery, you know, where they just have an anastomosis and you go poke through it, you know, or two, I guess, if they've got a big diverticulum hanging off and you get a big beefy NG tube and you ram it into their diverticulum. Other than that, if you see something like this, it will go into the airway. And typically you see projecting over the ones. This one projects very far out, so this went into the peripheral lung. Now, does anyone know what you do in cases like this? First, do you use the feeding tube? Help, people, do you use the feeding tube?
No.
Right, because you don't want to feed the lung or pleural space. Okay, do you pull it out?
I was going to say yes, but if you're asking, then it's probably no.
No, the answer is yes, but what do you do after you pull it out? Get an x-ray. Why would you get an x-ray?
To make sure you don't have a pneumo.
Yes, that's it. Good job, guys. Okay, good job. Yeah, because like it's hard to tell how peripheral it is on a single projection, right? Because if it's here, you don't know. It could be going posterior and go through the posterior pleura. When you see something like this is going right to the edge of the pleura. You know that, okay? And sometimes these actually punch through the pleura into the pleural space. And when you pull it out, you've basically pulled the cork out of the bottle, and you can get big pneumothoraces with this. So what I usually tell people for these is wait till radiology comes up for the radiograph. Pull it out, like, you know what I'm saying? And like, you know, like maybe like, you know, a minute or two afterwards, you know, by the time they get their stuff in there, you can get the image, you know, but I wouldn't pull this out and wait 2 hours for radiology to come up. So like I said, I get an immediate x-ray after pulling it. So I'd probably wait till radiology gets there, pull the tube, you know, like 5 minutes after they pull it, you get an image. You know, that way you can identify a large pneumothorax quickly, if you know what I'm talking about. So for like 5 minutes afterwards, 10 minutes afterwards, a slow growing pneumothorax you might not see, but then then you've at least got a little bit more time on your hands, if you know what I'm saying. But I would call radiology, get a radiograph, wait till they get up, pull the catheter, and then like, you know, 10 minutes after they pull the catheter, I get the radiograph then, type of thing. Just to make sure you don't have a big pneumo, and then repeat the radiograph in like an hour or something like that, or two, to make sure you don't have a slow growing pneumothorax, okay? Okay, that's really important though, because I have seen people pull these and they get a radiograph 2 hours later and they've got a huge pneumothorax on their hands. Okay, here's another one here. Anyone know what's happening on this one? Look at this, woohoo, right? This thing just doesn't even make a U-turn. This thing makes like a full 360 degrees, right? And its tip's like over here. So coiled in the upper esophagus. Oh, by the way, for these NG tubes, when they start doing things like that, I honestly don't even recommend repositioning. Just pull the darn thing out. You know, if something's like its tip is here, you can advance it and you should be okay, right? But when you have something like doing multiple loops in the esophagus, just pull it out and start from scratch, okay? Repositioning with something that's this badly mucked up isn't going to help very much, probably, okay? Okay, pneumothoraces and mimics. Any questions about NG tubes before I go on?
I guess I just have a question about this image here. I don't know, it just seems funky to me, like the left lung field's really black, and then there's something kind of weird by the cloud. Is there,
Yeah, so what happened here is that portable technique isn't very good. People tend to have low lung volumes, you have a lot of basilar atelectasis, and also in patients with a larger body habitus, you tend to have more soft tissues down here than up here. So to be able to window this part better or this part better might compromise another area. Do you see what I'm saying? Like, you know, one window doesn't fit all needs.
Okay, yeah, that makes sense, yeah.
Oh, and I'm sorry, like this one actually does a loop-de-loop and comes down here, its tip is in the lung. Sorry, we just almost didn't follow it down there. So there's the tip of the catheter there. And I window this to optimize evaluation of the catheter, and that's why the lungs don't look so good. So this one does a loop-de-loop with its tip down here. Okay, so pneumothoraces and mimics. Okay, so pneumothorax occurs when there's presence of air in the pleural space. And the real problem with a pneumothorax, and I just want to make sure you guys understand this. If you've got a small pneumothorax, that's not a problem in and of itself, okay? What's a problem is a big pneumothorax that causes like impaired cardiopulmonary function, right? And so if you just like do a procedure or something, they've got a small pneumo, that's honestly not a problem as long as it doesn't get bigger. That's the problem. That's why you want to worry, right? So, one, why is the pneumothorax there? If someone just had chest surgery, that's like expected, okay? And two, is it going to grow? That's the real problem, the growing pneumothorax, okay? So like I said, if someone just had chest surgery, you kind of expect it to be there. You just check to make sure it doesn't get bigger. If you have someone come in off the street with shortness of breath and pneumothorax, that's a problem, okay? There's not a good reason for it to be there, and you basically have to assume it's going to get larger, and get a radiograph to demonstrate that it's not, okay? And large pneumothorax can be life-threatening and require immediate needle decompression and/or chest tube placement. So these are the most specific image finding in a pneumothorax is a pleural line, okay? We see the pleura where you see lung next to it, and then on the other side of the pleural line, you see a loosened area with lack of vascular markings. This is it right here, okay? So there are other things that can mimic a pneumothorax, but this is the most specific finding, okay? So see here, guys, right? See this? You've got lung on this side. See the vessels, how they arborize? See your vessels coming out here, and all of a sudden, you've got like a little line there. See that line? Okay? And then on the other side of that line, not only is it more loosened, okay, but you lose your vascular markings. This is the most specific finding for the pneumothorax, okay? The pleural line with a lack of vascular markings, okay? Peripherally. Any questions on this so far? All right, now there are other things associated with pneumothorax, but they're not as specific. These are the specific findings, all right? So zooming in here, see that line there? Right there, okay? And on here you see your vessels branching. On the other side, no vessels. So once again, specific for a pneumothorax. Now, we'll briefly go over some atypical pneumothoraces. Yeah, let's take a look here. Yeah, this one's hard. Anyone? Oh, okay. Deep sulcus sign, I've got it right here for you. See all this like lucency down here? That's very concerning for a basilar pneumothorax in a supine patient, because when someone's lying down, remember air is not very heavy and not very dense, and it goes to the top, right, of a cavity. So when someone's lying down, this will be the highest portion of their body, supine. So the air will collect there. Okay, this is an example of the deep sulcus sign for basilar pneumothorax. This is a really hard one. You have all this weird stuff going on up here. It's kind of hard to know what's happening in there. This is actually a pneumothorax with just some like pleural, like some fibrous pleural fluid, maybe a little bit of adhesions, giving it a weird look to it. But you've got a chest tube in place, so I mean, there's nothing really to be like terribly worried about in this case. And some pneumothorax mimics. This is what I was saying with the mimic. This is a skin fold, okay? Now, people often talk about like the morphology of the skin fold. I think even more important and helpful than that is that you've got a radiodense line, okay? It doesn't really look much like a pleural line because you get a little bit of lucency just up next to it. And then see how the lung markings go across it, right? A pneumothorax in a normal patient shouldn't do that. Okay, if someone's had like, a lot of pleural disease, they have pleural adhesions, all bets are off. But in someone who's got a normal pleural space, never had any pleural surgery, a chest tube, empyema or anything, you would not see this, okay? So this is characteristic of a skin fold. Okay, everyone? And let's see here, another, oh, look at this. You've got more than one skin fold, look at that. Oh, and see here, you've got the line and then a lucency right next to it. That's very characteristic for air being trapped next to a skin fold, okay? But you see how the lung markings just keep going. See, they just keep going out. And that's, sometimes it's hard to tell, like, God, is that a pneumothorax or a skin fold? And sometimes like nobody can tell. What I recommend in cases like that, just get a repeat chest radiograph, and it'll go away if it's a skin fold. And if it doesn't, then you've got your answer. So, be aware skin folds can occur. Those are the findings. And if you really can't figure it out, one, I say call radiology first. And two, if radiology can't figure out either, just get another portable. It's quick, it's easy, and it should answer the question.
Sorry, this might be a dumb question, but skin fold, is that like an obese patient or something? I'm just trying.
I would say not as much obese as in patients probably who are older, who have some wrinkles, where the skin can't bunch up. Because if you've never seen them do one of these studies before. They take like an imaging cassette and they push it underneath the patient. So imagine you push the cassette under here, the skin can bunch up a little bit. You know what I'm talking about?
Okay, yeah, that makes sense.
So that's how it happens. But good question, good question. And this is hard here. Okay, so you see you've got like a line here, some lucency without markings, but that doesn't look like the normal. The pleural line should match the normal contour of the pleura, right? That's like weird. What is that? Anyone know? Use all your information. How about that? It's a big bulla. Okay, see that? So you actually get these things over here. You get big bulla. They occur like that. And this can be hard. If there's ever a question, call radiology and ask. But like I said, this is like does not follow the normal expected contour of the pleura. But like I said, if there's ever a question, just call radiology. Say, hey, I think that's a bulla. What do you think? And then take it from there. Yeah, this one's pretty hard. I think this is just a big giant like bulla or something like that. Either that or this. Every once in a while, like post-surgical patients, you get these like pneumos that just hang around for a while, and it's really weird. Like, do you have this chronic air leak, but they're stable and they just kind of live like that? Okay, and so, let me just finish this thing here. If you're uncertain about a pneumothorax, one I'd say, just call radiology and ask. If there's ever any question, you can get a radiograph in another position, upright to cubitus, see if the air redistributes. If there is a pneumothorax there, get a follow-up in 2 hours. If it's stable for 2 hours, I mean, it's probably not going to change. That's what we use like in interventional radiology. If a pneumothorax is stable, assuming it's small, right? For like 2 hours, you send them home. And if there's ever a question, like I say, you get the repeat. If that doesn't help, call radiology. They can always talk about getting a CT, but I would not jump to CT by default. Now, there was a question, I believe.
Yeah, this is going to reveal my lack of knowledge, but I've never heard of a lung bulla before. Could you just explain really quickly what that is?
Oh, yeah, sure. Like I said, no, please, I love these questions. I want people to understand. That occurs in patients with emphysema. So in emphysema, you get destruction of the central lobular nodule. Okay, and as that destruction increases and increases, and you get these coalescent areas of emphysema, they can form these larger air spaces we call bulla. And they can be pretty big, like you saw in this prior case here. Like that's pretty big. I've seen bigger than this, but like they can get pretty big. Okay.
So it's inside of the lung, within the lung.
Correct.
Okay. Perfect.
Yeah.
Thank you.
Yeah. Like, please keep the questions coming, guys. I want to make sure you understand.
I have one more question.
Yep.
I did a flashcard, and it was kind of the management of spontaneous pneumothorax is small versus large. And it said like a small is less than 2 centimeters, air rim on chest X-ray at hilum, and large is greater than 2 centimeters, air rim on chest X-ray at hilum. What is like the air rim on chest X-ray at hilum? What does that refer to?
Well, so at the level of, and this is hard, okay? So like this is the hilum here, okay? Right?
Okay.
So if you measure laterally like that, that's what they mean by air rim.
Okay, so it's on the outside there, like at the level of the hilum, you measure that.
Yeah, that's what they're talking about.
Greater than 2 centimeters, that's a large pneumothorax. If it's less than
and this is all relative, right? I mean, honestly, what's large is something that causes symptoms. I'll never forget. See if we have a tension pneumothorax here. Well, I had a case, like, I came in one morning and the patient's like heart was over here. Everything, like their entire mediastinum was almost shifted over. I mean, it was the worst tension pneumothorax, one of the worst I'd seen in my life. I'm trying to get a hold of the team to tell them like this guy's got a huge tension pneumothorax. And it took me a while to get a hold of them. They finally called back and said, oh yeah, sorry it took us a while to call you back. We're trying to convince this guy to let us put a chest tube in. I'm like, what do you mean you're trying to convince him? They said, well, he's asymptomatic and like it's breakfast time and apparently they were serving waffles or something and the guy really wanted to have his waffles. So he wouldn't let them put the chest tube in. So I mean, it's kind of crazy, right? But those rules are correct, but the biggest thing is symptoms. Like if you've got someone with a smaller pneumothorax, but they've got existing lung disease and they've suddenly become symptomatic, you might want to treat that. Whereas if someone's got a bigger pneumo and they're like doing fine and it's stable, you might not. So just realize that, what you said is like, a general rule, but you do want to take that in the context of symptoms. Okay, so pleural effusions, can occur for a variety of reasons. Here are some examples of effusions here. Now, you have opacity at the bases, and see it has what they call a meniscus sign. See how it kind of goes up on the sides like this? right? Kind of like if you were to remember when you're doing chemistry in college, how in like the volumetric beakers, how the fluid would go a little bit up on the sides and you were told to measure at the bottom of the meniscus, right? That's because of the surface tension of water, and this is typical of pleural effusion. So if when you start seeing this, like, peeking up at the edges here a little bit, the blunting of the edges, that's very characteristic for a pleural effusion, okay? Cardiomegaly, the chest, the heart should be less than half the diameter of the chest, right? And shown here, like if you measured that, that's less than half of here. This is greater. Or I should say that's an enlarged cardiac silhouette. It is very difficult to tell cardiomegaly from a pericardial effusion. Often in radiography, you cannot do it. So you would say this is an enlarged cardiac silhouette. Without prior imaging or something, I would just offer a differential of cardiomegaly versus pericardial effusion. Now, if you've got prior imaging and someone's got a big heart and it's still big and it hasn't changed, you can call it cardiomegaly. But yeah, just be cautious. Every once in a while, you get someone with like a pericarditis and a big pericardial effusion, and sometimes people miss those. And pulmonary edema. Let's see, I think we're getting close to the end here. Got to move on to the next talk. Caused from increased pulmonary venous pressures, and basically what you get are interlobular septal thickening, ground glass opacities, pleural effusion, cardiomegaly, and you can also on CT sometimes see enlarged lymph nodes. They get a little boggy. See these lines out here? They are called, come on people, interactive component. Anyone know what these are called?
Are those the curly lines?
Yes, curly B lines, absolutely. So great radiographic example of curly B lines. A worse case of edema here, you can still see some of the curly Bs with some, those would be interstitial markings, interstitial opacities, and these would be more airspace opacities in addition to just overall, just like the cardiac silhouette being big. And Dr. Mann will talk about the size of the vascular pedicle and pulmonary congestion. The problem with those findings are a little bit is that they really are only very good on PA radiography, and many patients who are sick enough to get imaging get a portable, and then those findings become less reliable. And esophageal dilatation, the esophagus, this is just a big dilated esophagus, right? It lives back there, a little bit of show and tell. And atelectasis can be due to collapse of the lung, parts of the lung, and these are your various lobes here. And so this is these linear opacities would be what we call subsegmental atelectasis. See right over there, linear. When you actually, wow, that didn't convert very well. So when you actually start having silhouetting of a part of the body, sometimes you get redistribution of other parts of the lung. You see that with larger areas of atelectasis, okay? So small areas of atelectasis can just be linear opacities. This is right upper lobe collapse. And this is right middle lobe collapse. You can see it on the lateral. But here you've got, what's this called? You're losing your right heart border, that's called?
Is that silhouetting?
Silhouetting, absolutely. Okay, so it suggests right middle lobe collapse here or consolidation. A little harder to tell on the two between on a frontal, but here you see there's volume loss in the right middle lobe compatible with atelectasis. Okay, and here you've got right middle and lower lobe atelectasis because you've got the right diaphragm silhouetted as well as the right heart border. And so versus consolidation, which occurs when something other than air fills the air spaces, and this is the blood, pus, water, cells, things that a lot of you guys have probably heard before. Pneumonia is very common, may present with a silhouette sign as I showed before. Another example, well, this isn't a pneumonia, this is edema, but yeah, just something filling the airways. And I'll briefly just mention pulmonary nodules, which are defined as a round opacity, which is well demarcated, rounded opacity, well or poorly defined, measuring up to 3 centimeters diameter. That's a nodule, yeah. And this is an example of a nodule here. Okay, so basically, very often it's hard to differentiate between, atelectasis, pneumonia, scarring, and cancer. And what I usually tell people, if you've got like an indeterminate opacity on a radiograph, just flip through a few of these examples of nodules. Some are infections, some are cancer. See them there? There we go. There, a little all over the place here, is that they're non-specific findings. They're generally benign but indeterminate. And if you see them on an X-ray, compare with priors. If they've been there for 10 years, it almost doesn't matter what it is, it's benign. Is it really a nodule? Is it something overlying? Is it a rib? Is it a button? And if it's indeterminate, my general rule of thumb is, if they have symptoms of infection, and it's ill-defined, and they don't have any history of malignancy or other obvious mets, I just get a repeat follow-up in a few weeks, presumptively treat for infection, and just make sure that it goes away. You want that follow-up to make sure. But if it's well demarcated, spiculated, no symptoms of infection, like chronic cough, weight loss, lymphadenopathy, additional nodules, get a CT. Every once in a while, you see a nodule on CT. And for those, we have fairly well-defined Fleischner guidelines, which make things a lot easier. And the radiologist will hopefully, just tell you what those are. Okay, great. So any questions? I'm going to move on to the cardiac portion here in just a moment. But any questions on anything I just went over in this first section here on chest radiography? Going once, going twice. Okay, so going on to a second here. Sorry, this is misbehaving. Okay, PDFs. It's weird. Okay. So let's see here. All right, so we're going to talk a little bit about cardiac imaging right now. Kind of flip back and forth so we can do some real-time looking at images. So cardiac, a brief whirlwind tour to cardiac anatomy is that there's several planes often used for evaluation of the heart, okay? This is, I'd say, probably the easiest one for most people to understand is the 4-chamber view. It's where you cut the heart kind of in half like this and you see the right atrium, ventricle, left atrium, left ventricle, okay? And you cut this through at mid-ventricle level going towards the base apex. This is the short axis view going through right about here, okay? 2-chamber short axis. They call the 2-chamber long axis going through right about here. And there's this one, which I'm always perplexed by. It's called the 3-chamber view, where the aorta is considered a chamber. I don't know why, but that's what they call it. Shown here are some recons I did on Terra Recon right there. Okay, and so we're going to walk through the heart. We're going to start with the superior and inferior vena cava, which supply most of the blood to the heart. And you can have contrast mixing. So here's the superior vena cava, inferior vena cava, and there's the right atrium. So going through this on the multiplanar formatted images, see right here, there's your superior vena cava. I'm going to put my cursor on it so you guys see where it is. Going down, there's your right atrium, there's mixing artifact, and there's your inferior vena cava right there. See that? And there's your inferior vena cava coming up, a lot of mixing artifact. There it is there. Once again, going up, and there's your superior vena cava right here. Whoops, right there. Okay, coming down. Now, they feed into the right atrium. There we go. And there are three afferent vessels to the right atrium, the superior and inferior vena cava, which we discussed, and the coronary sinus, often forgotten. And so there your superior and inferior vena cava. There is the coronary sinus. See it right there? Okay, it lives in the undersurface of the heart, right about, see that vessel right there? Okay, this drains the veins of the heart into the right atrium, okay? Every once in a while, you may get an anomalous like a left superior vena cava that drains into the coronary sinus, but typically it only drains the vessels of the heart. Okay? And once again, any questions, or if you want to see anything in greater detail over here on the 3D volume rendered formats, please let me know. I've got this loaded and I can scroll through it in real time. So yeah, if there's anything that's not clear, I should be able to hopefully clarify it by doing some real-time scrolling. The crista terminalis. So in the superior wall of the superior vena cava, see right there? Where is it? Right there. Right there. See that? That has formed a little fibro-fatty ridge right over there that can every once in a while pooch out into the lumen of the right atrium a little bit and can look a little nodular and can be a little bigger in some patients. It's called the crista terminalis, and that's a normal structure. Just beware if you're ever looking at cardiac CTs and you see something over there, just something to keep in mind. Other abnormalities that can exist here, most common is this is all just mixing artifact from contrast coming from the superior veins, mixing with unopacified blood from the veins of the leg on this arterial phase imaging. So very often you get a lot of mixing artifact here and things that look kind of weird. Ever any question about that, just call the radiologist and ask. And other things you can see in the right atrium are the fossa ovalis. It usually lives right about here. Sometimes you have some fat along the interatrial septum, and there's a little area of sparing. That's where you have the foramen ovale, which generally closes, however, it may remain patent into up to 15% of people on contrast enhanced echocardiography. So that's by contrast enhanced echocardiography. The numbers actually of people where it's patent is higher. But I don't know if you recall your embryology, when the foramen ovale closes, you have two membranes which grow past each other and then fuse. So even if those membranes have not fused, they've grown past each other enough that they still effectively prevent anything from getting across, even if they are technically not fused. Okay, and sometimes, so that's why on autopsy you can actually find that this number is higher, but practically speaking, nothing will go across. So it ends up being not clinically significant at all. You also have lipomatous hypertrophy of the intraatrial septum, and that's when the normal intraatrial septum right here is about 1 centimeter thick. And once it starts getting a lot thicker, like 1-2 centimeters, that's when you basically start calling abnormalities like lipomatous hypertrophy. Do note that that's really not clinically significant, which doesn't cause problems. Every once in a while, it can have a high FDG uptake on FDG PET imaging due to brown fat, and sometimes it's been erroneously attributed to a metastasis, but it's a normal structure. Okay, next we have the right ventricle. Centered on the left over here on this image, but the right ventricle is on this side over here. And so the right ventricle, a few key things about the right ventricle is the diameter of the right ventricle should be less than the diameter of the left ventricle, okay? That's important to remember in a normal patient. Okay, so just remember in terms of RV size, it should be less than the LV, okay? I just will briefly mention ARVD. You guys probably have heard about this. It's funny, I often think this is the least common diagnosis that everyone seems to be worried about. We always get studies requesting people evaluate for this, even though it's a very uncommon disease. Basically, you got on a microscopic level, get fatty replacement of the myocardium. That's not used in the MR criteria for evaluation. Basically, what you get on MR is RV wall akinesia, dyskinesia, or dysynchrony with possible aneurysmal dilatation, plus basically some marker of decreased RV function. Okay, and once again, going back to the real-time imaging here, there's your RV up there. And you see there's your tricuspid valve. You don't see it very well actually, but this is where your transition from your right atrium to your right ventricle. And then this over here is the aortic outflow pulmonary artery outflow tract. Shown here is the main pulmonary artery branching to the left and right main pulmonary arteries. I'll just briefly mention the upper limit of normal in size should be about, they usually say 30 millimeters. You don't really call it abnormal, and most people don't call it abnormal till it's like 33, because like 30 to 32 is kind of upper limits of normal in size, and above 32 millimeters is where people start calling it abnormal. Another marker for normal size is the size of the adjacent aorta, so it should be smaller than the aorta. Okay, the left atrium, shown here, there's the left atrium. And you'll note here, see there it is right over there. It basically has kind of like a cross-shaped pattern where the 4 pulmonary veins come together onto the left atrium. And so normally the left atrium receives 4 pulmonary veins. You can have more You can have less, but this is the most typical scenario where you have 4 pulmonary veins. I wouldn't worry as much about the diameter. Like I said, you can have some anomalies. And the areas of confluence, that's where you have branching close to the ostia, and that's more of a problem in electrophysiology where they want to do an ablation for atrial fibrillation. I'd say the main thing to remember is there typically are 4 pulmonary veins. And one other thing, do I talk about here? Yeah, the left atrial appendage. That's kind of a tricky structure. Here's your left atrial appendage right there. See it? I'm kind of, well, let me put my cursor over to it. Right there. See that? Oopsie daisy. Right there. See the left atrial appendage there? Now, see how long it is? And it's kind of got a little bit of a narrowing at the neck. That's actually not uncommon for the left atrium to kind of that area of narrowing right near its origin. See here? It comes out and then makes a right turn and gets a little narrow. So for that reason, 2 things can happen. 1, you can get mixing of contrast, and 2, you can get clot there, especially in cases of atrial fibrillation. Yeah, just something to be cautious of. Just be aware that, especially in cases of where someone's hypercoagulable or has atrial fibrillation, you can get clot occurring in the left atrial appendage. And, very often before cardioversion, a study will be done, either echocardiography, CT, or MR, to make sure there's not clot in the left atrial appendage. And there's also this thing called a pseudo lesion. I really don't like the name, but that's what they call it. So right here, see where you've got like the left atrial appendage and superior pulmonary vein there, there's this infolding of tissue. Every once in a while, that can get a little bit more lobular and nodular looking, and I've seen people misinterpret that it has been misinterpreted for an abnormality, but that's just normal, soft tissue septa between the superior pulmonary vein and the left atrial appendage. Left ventricle. So there's your left, you guys went to your left atrium, there's your mitral valve there. And you can't see the tricuspid valve very well due to the artifact, but the mitral you can often see a little bit better. Let me just see if we can zoom in there. See there, right? You can actually see the valve apparatus there a little bit. You've got the 2 leaflets of the mitral valve, okay, which are supported by, scrolling towards the apex, those guys right there, okay? Those are the, anyone know? Papillary muscles. Okay?
Papillary muscles.
There you go. Okay. Gonna just kind of trying to show it to you guys a little bit better here. Yeah, you can't see the chorda tendon, but you can see your papillary muscles there very well. They support the mitral valve apparatus and basically keep the mitral valve from prolapsing back into the left atrium. Okay, then we get, and so these are the papillary muscles. They're normal structures, and some people I've seen it referred to as papillary muscle bundles, because it's like there are a lot of like little muscle fascicles here. It's not, so sometimes people call it a papillary muscle, sometimes they call it a papillary muscle bundle, but there are 2 of them. Okay, for the halves of the mitral valve, and you have a little bit of cardiac pulsation artifacts. See that there? Yeah, you really don't have a discontinuous left ventricle here. That's due to some artifact. Yeah, you see right over there. You see that's just some artifact from pulsation. The normal wall thickness, well, they usually say it's the normal wall is basically about 10 millimeters. A little bit above that, you don't really start calling it abnormal. So it's one of those, there's normal, and at what point you call it abnormal, and the area in between. So normal is like 10 millimeters or less. You don't really call it abnormal until it's greater than 12, and kind of between 10 and 12 is kind of more like no man's land. It's not really normal, but you don't really call it abnormal either. So LV diameter, you realize don't really need to remember this, but I would remember if it, and one other thing I would comment about LV wall thickness is that on non-gated studies, that's, well, it's supposed to be measured at end diastole. So if for a non-gated CT of the chest, you don't know if you're imaging at end systole, where you expect the wall to be thicker, or end diastole. So if the wall looks too thick, on a non-gated study, it's hard. You can just, sometimes I'll say something like it's not gated. You might want to get a cardiac echo just to see what it looks like. But if you've got a gated study, you can be more definitive and actually say, no, the myocardium is abnormally thickened. So, okay, talked about the papillary muscles. I'm sorry, a question?
What's the difference between a gated and a non-gated?
Sorry about that. I should have mentioned that. So the heart, imaging the heart is actually really hard. right? Because not only is the person breathing, but the heart's beating. So you can have someone hold their breath, okay? But you can't ask someone to hold their heart. You know what I'm saying? Right, you can't get the heart to stop beating. So what you do is generally done using electrocardiogram. You'll measure the electrocardiogram signal, and there is a correlation generally between the electrocardiogram signal and phases of cardiac quiescence. That is, places where the heart really isn't moving very much. And generally at end diastole, right about after the heart is finished filling with blood from venous return and from venous return, the heart will generally tend to be moving the least, okay? And you can predict where that will be on the electrocardiogram. And what you do is you gate your acquisition. Either with acquisition or reconstruction, you gate the images such that you're only either imaging or reconstructing at a certain phase of the cardiac cycle. Okay, and by doing that, you can reduce cardiac motion in images. Okay, does that make sense for everyone?
Yeah, so a cardiac image that's gated, the patient's hooked up to an EKG, and basically the pictures of the heart are only taken at certain points in the EKG. Well, a study that's not gated, it's not?
Well, so they can either be, now that's actually kind of a little more complicated. You can either gate your acquisition or gate your reconstruction. So you can just like acquire throughout the entire cardiac cycle and say, okay, and that's actually often you'll get better images doing that if they've got an arrhythmia, and go backwards and say, okay, we gathered all these images, we have the EKG, and afterwards you reconstruct the images only at the appropriate phases of the cardiac cycle. You know what I mean?
Good. Thank you.
Yes, so you only put the images together based off of, when the heart's quiescent. And like I said, the reason you would do, the other way you only gate your acquisition reduces radiation exposure. But if somebody's got an arrhythmia, their heartbeat's not very regular, that can be problematic, and sometimes you just want to get the entire cardiac cycle. And there are other times as well, like we do what are called TAVIs. Have you guys heard of TAVIs for the aortic valve? That's where they put an artificial aortic valve in there. We'll actually acquire during the entire cardiac cycle, see how the valve moves, look at what the maximum valve area are, aortic annulus area. And there we do an intentional acquisition and reconstructions for the entire cardiac cycle. But the acquisition, we still call it gated, right? Because your reconstruction is based off EKG, retrospective. It's a retrospective reconstruction off of the EKG. So yeah, it's a kind of an awkward term in that regard, but yeah, that's what it's used for. So the left ventricle, one other thing is, like, every once in a while, the trabeculation of the left ventricular wall, see how like you've got like some non-compacted muscle here at the edges? That's normal. How much is too much? Well, if your non-compacted myocardium is greater than 2.3 times your compacted myocardium, that's when they basically is called cardiac non-compaction. Yeah, that's a disorder that has associated morbidity, mortality. Not really too important to remember this exact number, but just remember that people can have too much non-compacted myocardium, and that can be an issue. But you don't need to remember this number. Yeah, and yeah, this is just some tables with ventricular sizes. You don't need to remember this either. I just threw it in there for like the residents need to remember this a little bit more. And if anyone's really interested, I'll be going over this citation here at the end of my talk. Okay, now, technically not part of the heart, but I'll just briefly talk about the aorta. And so your proximal ascending aorta here, right? First you have your aortic annulus, which is where your aorta originates at the base of the heart, and then your sinuses of Valsalva and your sinotubular junction. I'll briefly go over that here. Let's just reset this thing. And so basically, here's your left ventricle. We call this the aortic outflow tract. Let me just zoom in here a little bit more. Yeah, so basically here's your aortic outflow tract right below the level of the sinuses of Valsalva. See here coming in, so right below we call the aortic annulus. It's really not a very well-defined structure. It basically occurs right below the level of the aortic valve. And this is your aortic valve. We call these the sinuses of Valsalva. There's one of them corresponding to each of the aortic valve cusps, okay? And we call each of these areas here the according associated coronary artery. So this would be your right coronary cusp, left coronary cusp, and does anyone know what you call the cusp without a coronary artery? Non-coronary cusp. It wasn't a trick question. And so you'll notice here, like the normal is to have your coronary arteries originate off of the sinuses of Valsalva. Interestingly, this patient here is a very normal, except for one thing, okay? Just try to zoom in here. His left coronary artery originates above, right at the sinotubular junction, above the left coronary sinus. Abnormal, but yeah, otherwise this is a very normal study. Okay, now going up, so that's your aortic root. That's your sinotubular junction where the sinuses of Valsalva kind of transition to the ascending aorta. And then you've got your ascending aorta right here. Okay, and we're not going to go into like the aortic arch branch vessels and stuff. That's not really cardiac imaging, but I at least wanted to talk about the aortic root. Okay. Oh yeah, and just basically, so the aortic size is actually, our normal aortic size is actually pretty complicated. It varies with age, gender, and body habitus, right? If that just doesn't make things confusing, I don't know what does. So there really isn't one normal size for the aorta. So you can see here for like younger patients, like if you've got a 20-year-old with an aorta that's 35 millimeters in diameter, that's very abnormal, okay? But if you've got like a 90-year-old, a normal aortic size could be 45 millimeters. And realize again that this varies with body habitus and gender as well. So just be aware that the aorta, the limit that a lot of people teach is 40 millimeters as being normal, upper limit of normal. Just be aware that it's not quite that simple. You don't need to remember these numbers though, don't worry about that. Okay, now the pericardium. Yeah, so the pericardium extends around the heart. The pericardial recesses can be a little bit tricky. So I just showed you right over there some of the pericardial recesses. Let me just reset here. Yeah, so see right over here, oops, zoom out a little bit, zoomed in a little too much. You see right over, God, this guy doesn't have a lot of pericardial fluid. You don't see it very well here. See right over there, you see a little bit of a line. That's the normal pericardial sac. And right in there, see right over there, that's the pericardial sac. This area is called the transverse sinus of the pericardium, kind of right on top of the heart between the aorta, the pulmonary veins, pulmonary artery. See all this over here, that's just little aortic pericardial sinuses, the recesses of the pericardial sac, excuse me. Right over there, see extending anteriorly and posterior to the aorta. So that's the pericardium. Yeah, so I was just going over the normal anatomy. If this becomes abnormally distended with fluid, you call it pericardial effusion. It's hard to decide what exactly qualifies as a pericardial effusion because you just do have physiological pericardial fluid, and so it can be a hard call to decide when something's enough to be called a pericardial effusion. And also, basically, the pericardium should be thin. Abnormally thickened pericardium, you worry about pericardial inflammation. And so we went over that. Okay, okay, so I've got a few references here. The only one that I would say might be applicable to you guys would be this one. This is a really good article, just a big picture overview of cardiac anatomy. And so I'd say this one is something that would not be inappropriate for you guys to read. Some of the other articles I think would be way too much detail. But this one actually does provide a very nice basic overview of anatomy. It's CT focused, but I mean, the anatomy doesn't depend on what modality you use to look at it. So I'd say this would be applicable to any cardiac imaging technique in terms of the anatomy taught. Okay. Cool. So I'm going to be talking a little bit about atherosclerosis coming up next. Are there any questions before I do that? Any questions? Okay, so going on next, we've got a cardiac CT of ischemic heart disease. I'm just going to go through this really briefly here. So basically, I'm not going to, you guys are probably familiar with a lot of this stuff from being in medical school. A lot of this is for resident review. So I'll just go through it briefly though. But I'm sure many of you know, I mean, heart disease is, you know, the leading, sorry, cause of death in the United States and many other more affluent countries. Yeah, so this is due to a buildup of plaque in the coronary arteries leading to luminal narrowing and impaired blood flow to the myocardium. Atherosclerosis is basically due to an imbalance of lipid metabolism resulting in chronic inflammation of the arterial wall. And this inflammatory process may lead to chronic and or acute narrowing and myocardial ischemia and or infarction. The chronic inflammation of the arterial wall has a predilection for areas of turbulent blood flow causing endothelial injury. Remember Virchow's triad, you know, endothelial injury causing clot and stuff. Well, also you see similar things here in terms of wall inflammation. And this leads to deposition of low density lipoproteins and formation of plaque. So here's a normal vessel, and there's basically your plaque deposition. And I think I talk a little bit more about the plaque structure here, but basically you've got your intima here, you get lipids deposited in your intima, and you get this like fibrous cap over it, which basically tries to protect your body from the thrombogenic lipids, okay? And these may be resorbed, and this is partially mediated by high density lipoproteins, remember the good HDLs. And this lipoprotein deposition can incite an immune response with infiltration of white cells, leading to fibrofatty streaks. You know, and they try to mop up these intracellular lipids. And these plaques are covered by a fibrous cap, causing various degrees of narrowing. And so depending on the characteristics of the plaque and the cap, you have varying degrees of probability of rupture. So the higher degree of rupture, with high degree of rupture, call that unstable plaque. Okay, and so here is your, you know, your lipid core, your fibrous cap, and like I think over there they're actually trying to show, yeah, like a rupture. Okay, and remember this: these lipids are very thrombogenic. So if this ruptures, this area is prone to acute thrombus formation and acute coronary syndrome. So for stable angina, is related to increased myocardial oxygen demand for fixed lesions, okay? And so what that means is, let's say you've got an area of like a big goober of calcium in your coronary artery. I mean, that's not going to change anytime soon, right? You know, the calcium is stable. You're not going to have thrombus formation associated with it. But it's a fixed lesion, so if someone does a lot of exercise, they're going to have myocardial ischemia, okay? That's called stable angina. Acute coronary syndrome or unstable angina is basically where you have an acute narrowing, okay? And your myocardium's unable to meet, your blood flow is not able to meet myocardial oxygen demand at rest, okay? And that's a major cause of death in CAD. And basically what happens is you've got your plaque, the plaque ruptures, and you've got this big thrombus causing, you know, rapid, severe narrowing or occlusion of a coronary artery. Here's an example of a histology specimen shown with a lipid necrotic core, the fibrous cap there is ruptured, and that is, what is this, people? Interactive component. Okay, this is clot, basically a big clot in the coronary artery. And calcified plaque, this is interesting. We often use, you guys heard of coronary calcium scoring? Let's get a yes or no. It's a helpful to have a look. Okay, so generally speaking, a higher coronary calcium score is considered bad. Interestingly, though, that's stable plaque. So it's a risk marker, but so it's funny, like I've heard that when they start people on statin therapy, their coronary calcium will increase. Score will increase because their unstable, you know, soft plaque will calcify, become stable plaque. So it's a marker, but just realize that it's actually not the problem. It's a marker of a problem. It's a marker of coronary artery disease, but the stable plaque itself is stable. That's not going to cause acute coronary syndrome. Interesting little caveat. And just briefly with cardiac anatomy, I'm just going to go through it over here. It's a little easier to show you guys in real time. So this right over here, coming off towards the anterior chest wall and sternum, is the RCA. So sometimes when you're looking at these coronary images, it's hard to know where the heck you are and what vessel you're looking at. But what I like to remind people is that the RCA comes off towards the sternum, okay? And it courses in the anterior atrioventricular sulcus, wraps around the inferior aspect of the heart, and generally, see right over here, it supplies the, it's a little bit of motion, but you can see it here supplying the posterior descending artery. So in most people, they're right dominant, and the RCA supplies the inferior wall of the heart, right here, okay, down the bottom. So for most patients, like 85% are right dominant, and their bottom of the heart, the inferior wall of the heart, is supplied by the RCA, okay? Oh, okay, well, I'll just go to RCA here. Yeah, so that's the RCA there in the atrioventricular sulcus, and like, okay, sorry, 70% of people are right dominant, 20% co-dominant, 10 are left dominant. Now the left coronary artery, okay, sorry, the left main is right here, okay? That supplies the circumflex artery and the LAD. And in this case, they've got a trifurcation where the three vessels split. It's kind of like almost like a trident appearance. And this third artery here is called radius intermedius. If we're a little bit more in either direction, you'd say it was a tributary of either vessel, but when it's a trifurcation, you call it radius intermedius. The LAD courses down in the interventricular sulcus here and supplies the anterior wall of the heart. The circumflex artery there supplies the lateral wall and a bit of the inferior lateral wall of the heart. And very often, if this were either a diagonal artery off the LAD or a obtuse marginal off the circumflex, this would support part of the anterior lateral wall of the heart, okay? And that's your whirlwind tour of coronary artery anatomy. Now, there are a few other branches that are named and people talk about, but I think for the purposes of this lecture, what you guys need to know, just knowing your basic coronary anatomy, that the left main supplies the LAD and circumflex. And as we said here on the next slide, most people are going to be right dominant. About 70%, the inferior wall of the heart will be supplied by the right coronary artery. That is important to remember. Now, I will just mention this. You guys don't need to remember this slide here, but basically the walls of the heart are broken down into what are called segments that correspond to the typical vascular anatomy of the heart. And so basically, if you can say, oh, well, like, the anterior segments 1, 7, and 13, and the apex are like, not being perfused, that would correspond to the LAD. Okay, and of course the anterior lateral wall. And shown here, actually, the, I'm sorry, a little bit of cough here. Shown here are how the areas of the heart in the 17 segment model correspond to the typical vascular distribution. Now, like I said, note before, as I said, that the inferior wall here, that's where you might have right or left dominant, and it can change, but typically this is going to be supplied by the RCA. So you guys don't need to remember this, just do know that there's a way of breaking this up if you ever see this plot. And the reason that's done is because this corresponds to the typical vascular anatomy of the heart. Abnormalities in these areas can tell you which vessels are diseased. Okay, but like I said, don't worry specifically about that thing itself. So there are a lot of visits to the emergency department for chest pain. And they're, I didn't give you all the criteria here, but the typical things that are used are like, it's either non-cardiac chest pain, like, like somebody like falls and hits their ribs, while they're riding their bicycle, it hurts where you press down. That's it's non-cardiac chest pain, okay? And then you've got your typical anginal pain, which has very, definitive characteristics here as listed here. And then you've got everything in between, which is atypical, okay? So how to treat possible acute coronary syndrome is very difficult because very often the symptoms are non-specific. You get some that are, get some cases that are not clearly non-cardiac, some that are very much typical angina, but a lot falls in between. There are many ways of working this up. So if someone comes in with more cardiac type chest pain, very often they'll do an EKG, a troponins. If those are negative, right, and they're not actively having a myocardial infarction, there are many tools that can be used for imaging. And so the older ACR criteria actually listed appropriateness, gave it a ranking, and coronary CTA was right at the top because it has a very, and this is, and that's for where you have chest pain with low to intermediate probability of coronary artery, acute coronary syndrome. Okay, so coronary CTA works very well in those instances. I'll discuss why in a moment. Whereas if someone's at higher risk for acute coronary syndrome, there it's more appropriate to go on to invasive angiography as first line. Obviously, if someone's having an acute myocardial infarction, they've got elevated troponins, they may go to the cath lab immediately. One interesting, I'll get back to that in a moment. And so for CTA of ischemic heart disease has become more common. And part of the reason for that is that it has an extremely high negative predictive value. Now that's important to remember. The negative predictive value is what makes this such a strong technique. If you've got a low likelihood of disease, this is really good at saying somebody's normal. If they've got a normal coronary CTA, they basically don't have coronary artery disease. So that's what makes this so strong. Yeah. Oh, the one thing I said before about even with an elevated troponin, every once in a while you'll get a young patient coming in with an elevated troponin, like a 20-year-old. In those cases, more likely than not, it's going to be like a myocarditis. So historically, they used to cath those patients, anyone with an elevated troponin. Now it's typically, okay, they're young, they probably got myocarditis. Some places will do an MR to look for MR findings of myocarditis or pericarditis. And I've seen some people, also, that's been more common, but in cases with contraindications to MR, you could just think about doing a coronary CTA. And if the coronaries are clean, then it's not a myocardial infarction, you can treat presumptively. Examples of luminal narrowing, calcified plaque, non-calcified plaque, don't need to worry about that so much. For CTA, there's just some, contraindications of coronary CTA, or just your general CTA contraindications. MRI can be done as well. This tends to be better for soft tissue characterization and what's what I'm looking for, diffuse heart disease, like your cardiomyopathies, generally not for, cardiac ischemic heart disease, although some places do cardiac, I'm just blanking on the word right now. Some places do perfusion MRI. So it can be used, but generally it's not typical right now. And the main reason you really want to do this is for delayed enhancement imaging and perfusion imaging. And so delayed enhancement imaging, if you see areas of delayed enhancement, that will correspond with areas of infarction. Excuse me. And for areas of infarct, areas of ischemia and delayed enhancement tend to be subendocardial. That's they hug the wall, interior wall of the left ventricle, and extend towards the surface. So that's actually fairly specific for areas of myocardial infarction. So, and they also have that follow vascular territories. Not really important for you guys to remember, although I just want to let you know it exists and delayed enhancement exists. Okay, and so CT, especially in MR, is very useful in cases where you're worried about acute coronary syndrome. MR is more useful in cases where you're worried about. You can also use it for areas where you're worried about is cardiac ischemia, although it tends to, from my observation, be used more in cases where you're worried about more diffuse heart disease. And delighted to answer any questions before we go on to our quiz questions. Okay, so nobody's asking questions right now. So what we're going to do is, do you guys all have, can I get a thumbs up or thumbs down, or people call in or something and let me know if you've got the quizzes? Does everyone have the quizzes?
Yep, we all should have them.
We have them.
Okay, so why don't we take like 5 minutes? And is there another lecture after me, or can I run like 5 minutes over going over them?
You should be the last one.
Okay, cool. So I mean, so why don't you guys would it sound reasonable to take 10 minutes, then we can maybe to go like 10, 15 minutes over going over the answers? Does that sound good to everyone, or does anyone have a problem with? Is there an issue with that?
Yeah, that sounds great.
Okay, so why don't we plan on guys have like will be 9 minutes for those 2 quizzes, and we'll get together at 3 o'clock. Okay?
Quick question.
Sure.
To me, it looks like there are 3 quizzes. Like there's one on
Hey,
intro
I
to
just have
chest,
something at.
intro to cardiac, and then a third one that has stuff about tube feeds and endotracheal tubes and whatnot.
Boy, that's not mine. I only have 2. Let me
So Bill,
show you guys. Okay, so the quizzes I've got for you guys are this quiz intro to CXR and quiz intro cardiac imaging. Those are the quizzes for me. You might have a quiz from somebody else, okay? All right, guys, so we'll reconvene in at 3 o'clock and see if people need a little bit more time since we discussed this now, okay? I'm gonna mute myself.
Do we need to submit our quizzes to Serena before we discuss it, or we?
Yes. Oh, they need to be submitted before we discuss. So I will at 3 o'clock. I'll make sure people don't need a minute or 2 more, and then I will definitely say you need to submit this now because we will discuss it, and anything after that will not be considered, acceptable. Okay.
Gotcha. Thank you.
All right.
Dr. Olpen, do we have another lecture about the intubation by Dr. Aquino later today?
Do you know what?
Or are we done after that?
Snafu with the schedule. We were under the impression that Dr. Auffermann was just going for an hour, but he took 2 hours, which is great. And so we're going to reschedule Ricky Aquino another time.
Yeah.
Oh, thank you so much.
Yeah. Okay.
Sorry
great.
for that snafu.
Oh, well, okay. Well, guys, like I said, then we can go over stuff afterwards, and yeah, have some time for that. So we'll reconvene at 3 o'clock and make sure everyone's okay. Okay, once again, everybody, as I said before, at 3:03 in a few minutes, if you have not emailed Serena Estrada, we'll make it 3:04. Okay, give people 1 more minute. Email Serena Estrada the answers for your quizzes. If they are not time-stamped by 3:04, 15:04 hours, they will not be accepted for grading for this course. So if anyone has any concerns, please send me a text, a chat message on GoToMeeting now. Otherwise, we'll reconvene at 3:04 hours and discuss the answers, at which time, you won't be able to submit your quizzes for grading anymore. Okay, so no one has, no one's voiced any complaints, so we're going to go and get started with going over the quizzes now. And please, if there are any questions about the things that I go over, do let me know. I want to make sure that people do understand everything, okay? So first question is, so select the best answer to each question. I tried to make these easy, guys. I tried to make them applicable. Why is it important to provide patient history when ordering a radiology study? Okay. It's answer E, C, and D. It's needed to protocol the exam properly, select the appropriate examination and how to perform it, and it's also needed to interpret the examination correctly. So remember that example I gave of, like, the 28-year-old male with fever and cough and the 82-year-old male with chronic cough, weight loss, and history of smoking? Yeah, the same radiograph, you'd interpret those pretty differently. Okay, so the correct answer for question 1 is E. This is intro to chest radiography. Okay, this one here. Next one's gonna be separate. Question 2, why is it important to have 2 orthogonal views of a structure? Because it can help account for superimposed structures. Okay, some of these also may be applicable, but this is the best answer. This is why you do it, okay, to account for superimposed structures. And please, if there are any questions as we go along, do chime in and let me know, all right? The silhouette sign occurs when? And the answer is 2 or more, 2 structures of similar radiographic density are in contact, right? They really do need to be in contact, because otherwise the probability of the silhouette sign occurring is near 0. That's question 3. Question 4, when ordering, the ordering of radiographic densities from least to most dense is B, air, fat, water, soft tissue, bone, and metal. Okay. And question 5, the most specific, remember, finding for pneumothorax, the most specific findings for pneumothorax are B, the pleural line with loss of lung markings peripherally. Some of the other findings can be seen, right, but they're not as specific. These are very specific findings for pneumothorax. Okay, and any questions on those? I hope I hit all those points in the lecture for everybody. Any questions? Going once, going twice? Okay, moving on to the next one. Next quiz, cardiac imaging. Okay, so this is a quiz on cardiac imaging. Once again, select the best answer. Question 1, the right atrium normally receives blood flow from what number of efferent vessels? The answer is 3. Remember the superior vena cava, the inferior vena cava, and the coronary sinus, the one that people tend to forget about. Any questions there? Okay. Question 2, the normal diameter of the right ventricle is, and the correct answer is B. It should be less than the left ventricle. I wouldn't worry, for right now about specific sizes. Just know it should be less than the left. I think, for just an intro, that's all you guys should need to know. Question 3, the number of papillary muscles present in the left ventricle or papillary muscle groups is B, 2. Question 4, which coronary artery usually supplies blood to the inferior wall of the left ventricle most commonly? That would usually be the E, right coronary artery. Okay, about 70% of the time. And question 5, coronary CTA is helpful in evaluation of chest pain with suspicion for acute coronary syndrome because coronary CTA has a very high D, negative predictive value. That's the true value of coronary CTA in concern for ACS, acute coronary syndrome. All right, guys. So any questions on anything we went over, or just radiology questions in general? I'm delighted to answer or help you guys out with anything. Okay, well, I'm not getting anything over here saying thank you. Okay, I'm getting a bunch of thumbs up. So like I said, I'll give you guys any questions going once, going twice. Sold. Okay, we are done for the day, guys. Thank you so much for tuning in. And if you do have any other questions, please do feel free to shoot me an email, okay? Have a great day, guys. Good night.